outcomes. So HIA can have very tangible results. This project here, home in Tacoma, is Tacoma, Washington's missing middle policy. How are we going to provide affordable housing within the framework that we have? We, in conjunction with their environmental impact assessment, there was an HIA done. And really, we looked at what are the differential impacts, where is housing most needed versus where is housing going to be most disruptive. Disruptive in terms of tree canopy loss, disruptive in terms of heat island effect, or disruptive in terms of people not having a decent place to live. They're not being good housing quality. And really, it got the community involved in a very different way in this, because people who were homeowners, single-family homeowners, were like, we don't want apartments, and we don't want, garage apartments, we don't want these things. But whenever the community that was impacted, the people who needed housing, the people who lived in areas where it was already hot and treeless, got involved, their policies got better. We reshaped with the community their anti-displacement policy in accordance with this. So HIA can be very powerful. It can be a tool for community voice, and incorporating lived experience and the community's requirements is a key tenet. Maybe I can get this thing to work. Let's see. So the elephant in the room, right? Whenever I talk to people about HIA, they say, oh, it sounds really fantastic. Who's going to do it? How much does it cost? And it seems like it takes a really long time. Right? There's not a lot of funding out there. We went through an era where there was a lot of funding for HIA, primarily from the CDC, and it really took off. But then, there was the lull in federal funding. The EPA was funding some HIAs. It is an eligible activity under several of their new grants, and I'm hoping to see more activity because it's not horribly expensive. They've been done, like I personally have done one for $10,000 where the community got most of the money. Right, because we were paying the community members for their time. We hired a community member to be our outreach coordinator, and that's where most of the money went. Right, we did things like whenever we had community meetings, we provided dinner, we provided babysitting. We made sure that people who were on shift at that time had an opportunity to participate as well. We did multiple meetings. Right, so there's ways to minimize the cost, activating your community partnerships. But primarily, right, these are done in the context of federal funding. So what makes a good HIA? How do you set your process up for success? When we look at the 6 phases of HIA, there's not one that says trust building, right? There's not one that says community building. There's not one that says, go there and be in community with people and figure out what they want first. So we have to make sure that when people are doing HIAs, that it's not necessarily somebody that's been contracted from outside the community that doesn't know people or doesn't know how to be in community. Your health department is a trusted community resource, and I know since COVID, people are like, oh, my health department, but health departments are in the community every day, especially your chronic disease and your environmental health partners, and they can help. But making sure that you understand what the community wants, what their conditions are on the ground, what's happened there in the past that might set up barriers to trust, and how to work with those situations, how to talk to people so that you understand what those sensitivities are, and also making sure that the community understands what they're going to get out of this HIA. Right? You can't be extractive. You can't go in there and say, well, we want your help. Come and help us design this. It has to be very clear what their benefits are, why they should engage, and how this is going to change their community for the better over time. And you have to value their time and expertise. And if you can, by all means, please pay for that, right? You're getting paid as a staff person to sit there in all of these meetings. Community members are not, usually. We will figure this out. There. So there are, as I mentioned, 6 phases of HIA. And we're going to go through them. But the thing to remember about these phases is that they're recursive. And what I mean by that is that they're iterative. Once you're finished with screening, the answer is do an HIA or don't do an HIA. But the rest of the phases are very much a work in progress. They're very much you refine as you get more information. So if you think about how the process works, right? There's an information funnel that's like this big. And as you're narrowing down what this project is, what the HIA is going to look at, who are the impacted communities, you're getting more and more information. So you want to go back and make sure that you're re-examining your last phase and making sure that you've incorporated all the new information that you've gotten. So the first phase is screening. And screening really is, should we do the HIA? Is health already incorporated into whatever this decision is? If it's a regulatory decision and, say it's an air permit, are they already considering health? Have they already modeled the health impacts? Have they already, done community outreach, looked at underlying vulnerabilities? And is that accounted for in the process already? Sometimes it is, sometimes it isn't. Regions do their permitting quite differently. And then, do you have enough time to do this HIA? There's a lot of different ways to do an HIA. You can do one as quickly as 6 weeks. You can do one over, 6 months. You can do one over a couple of years. Do you have enough time to complete the process before the decision is made? Because the key to HIA is impacting the decision before it's made and making sure that all of the contingencies have been thought of. Do you have enough resources? Do you have enough community trust? Do you have enough staff time? Do you have enough expertise? Are there experts that you can bring in, right? So what do you need? Do you have all those resources? And making sure that the decision to be informed is very clear, is because whenever you're thinking about what are the health impacts, it's really key to have a clear decision that you're looking at. So if the decision is, should we rezone this piece of property from commercial to residential or vice versa, then making sure that you're looking at that decision and not these other ones about, well, should we build housing or should we build, right? Like it's the land use decision and making sure that you're focused in on that. And then, will the community accept the results, right? I'm working in a community right now that has had a Superfund site. They've had an ATSDR study. People have been coming there for 40 years and they have studied these folks. And, they come and they say, oh, these things are wrong. You've got your harbor's all polluted with PCBs and it's in the air and you guys have been breathing it and, see ya. That's right. And they are not interested in another study, right? They are interested in finding out if they are being lied to about the poison that's coming into their community. So the group that I'm working with, we are not just bringing them the data, the health data, the environmental data. We are having charrettes with them, and we're saying, does this seem real to you, right? The data that Massachusetts Department of Health has says that cancer isn't higher here. But we know that within a 4-block radius of this brownfield site, we know that cancer's really high. But they're being averaged out in that statewide data. So getting that micro data and having the community on board to sit with me and tell me their family history, to sit with me and validate how far out does this cancer cluster, not the official kind, but the kind that you can see on a map, how far out does this go? Because people are dying, and the elders are dying, the people who know the stories. of the weeping wall where the chemicals were just slushed down the wall, and the wall was coming out, it was coming out of them into this community, right? A tool and die plant. So making sure that you have the community's goodwill and that they will help you in this process, because nobody does a good HIA without the community. Proper screening and scoping really lays the foundation. It gives you the justification for the HIA. Why are we doing this? Who's impacted? Who's important? Whose voice needs to be at the table? Who are the stakeholders? Making sure, as I said, you have a clear decision and you know who the decider is. Sometimes it's not clear who's making the decision. It could be a group of people, or it could be, the zoning board and then the county commissioner. So making sure you know who's making the decision and that you clearly define the roles and responsibilities, that the community understands what you're doing, what their role is, and what the expectations are on the back end. Because there's nothing worse in the world than working with the community and saying, everything is possible within this context, right? And having them give you a bunch of great ideas that no one can afford to do and aren't maybe within the regulatory framework. So making sure you're setting those expectations and that everyone understands the process. Your decision context is really important, right? So thinking about in your screening, do you have legal authority, right? Sometimes agencies don't have legal authority to do the HIA, or they feel that their legal authority is squishy, and so they won't step out on a limb and do it, right? Sometimes agencies say, well, we could do the HIA, but what if we find bad stuff? Right? We don't have any money to fix it. So maybe it's better not to know if there's PFAS in people's water. I've heard that one, trust me. Resources and time, we talked about that, right? Laying out a project plan, knowing what it's going to take, how long it's going to take, who you need, and what expertise. Knowing the context of the decision, right? This didn't just pop up this week. This is a community that's been here for a while. So is there bad blood? What do you need to know about, say, air quality in this community? And then really thinking about your baseline conditions. What are the health, the current health status of the community? Is there a high lead levels? Are there underlying respiratory issues? Knowing the baseline conditions not only gives you a place to project from for health impacts, but it also tells you what is going to be important in considering underlying vulnerabilities. So if you have a lot of children with asthma in your community, maybe you want to look at multipliers for air quality, right? What would make them more susceptible? Because they're children already and they already have asthma. So making sure that in your solution set that you have really accounted for that and said, okay, we have all of these kids who already have issues. What do we do? Do we put screens for their windows? What do we do? And then your initial engagement. So this is the point where once you've done your baseline and you understand what the decision is, you have your initial engagement with the community. You say, this is what an HIA is. This is what we're doing. This is how it relates to you, and this is how you can be helpful. But really making sure that you have done your root cause analysis, right? The only way really to predict health impacts is if you know what the underlying causes are, right? It might not be that it's, the building that they want to build on the former Brown site. Maybe your other vulnerabilities are, there's a PCB Superfund site nearby that's blowing air, right? So you want to make sure that you understand what the root causes are of the vulnerabilities that you see on your baseline health analysis. And like we don't know, right? Like there's no way to know what causes exactly this or that, but we know by doing a literature review that we can say, this kind of concentration creates this kind of vulnerability, say for an air pollutant, to go back to my original example. And by looking at the literature that's out there, looking at other HIAs, looking at health studies that have been done in similar communities, and looking at their outcomes and their vulnerabilities will really give you a good place to start. And then the thing you're going to do once you have done your literature review is you're going to create this pathway diagram. Whoops. Maybe I took that slide out, sorry. A pathway diagram is basically a logic model that says, here's the policy, plan, program, or process, right? Here's so say your policy is creating more walkability in our community. So then your first box on your logic model would be build more sidewalks, right? And then the next one would be build sidewalks, people will walk more, right? People will walk more and they will be less obese or overweight, right? That's sort of the logic model that you want to build out, bless you, for each of your health impacts in your pathway diagram, so that as you're trying to predict outcomes, you will have a clear path to see that. And then also making sure at this point that you're creating your stakeholder maps, that you are working with trusted community leaders and community-based organizations to know who the primary, secondary, and tertiary stakeholders are, so that you will know when to include them in the process and how they want to be included. So this is the point where you'll contact them and you'll say, here's what we're doing. Maybe you'll hold a big stakeholder meeting and you'll say, here's how we see your involvement. How would you like to be involved, right? And making sure you're building this sort of coalition of the willing. And then lastly, your engagement plan. Once you have your stakeholders identified, you can identify where in the process you want to engage them, how, if you want to, engage them in dialogue, if you want to inform them of progress, or if you need their committed involvement. I'll get the hang of this. During scoping, you really work with your stakeholders. They will tell you, a lot of times, they know what their health impacts are, right? They know what happened when the plant closed down and it was abandoned. They know what their well water tastes like, right? They know what's in that nasty stuff in their basement. They'll tell you. So making sure that you're having those conversations with them early and often in the scoping process, because this is really where you're defining what the parameters of the HIA are, right? What is your your geographic scope? Who's involved, right? What's the extent of the impacts? Are you going to look retrospectively as well as prospectively, right? So that you can understand the full vulnerability. Are you going to just, predict 2 years in the future because that's when the plant will be built, right? So thinking about what are your geographic boundaries, what is your time boundary, right? Because HIAs are temporal. Who are your impacted community? And really, what are the impacts that are the most severe or that are the most of concern to the community? You can't possibly look at every health impact that comes up in the literature or even ones that you think are going to happen. Pardon me, I prioritize these usually with the community, and I explain to them, red, yellow, green, a lot of times, here are the ones that are really impactful because and I tell them why, right? It's red because it impacts everybody in this community. It's green because it's just the people who work outside, or, it's yellow because it's everyone who's outside, right? So thinking about not just what are those vulnerabilities, but how do you communicate those so that people have a reasonable expectation of how dangerous things are. And you really are making a map in the scoping phase, right? It's a map of your process. It's a map of where you think the people are that are impacted. It's a map of where the impacts are occurring, and making sure that you are also taking stock of what the stakeholder capacity is, right? Because sometimes people are just tired and they just cannot go to one more meeting. Right? So how do you make this accessible to people? Is it doing online? Is it, being in the community more frequently instead of having these big meetings where everything is decided, right? What does that model look like? And so you're setting that up. You're also thinking about your timeline for the process, right? How are you going to get this done before the decision is made in enough time to provide advocacy and education to the decision makers? Because what you're really trying to do with this process, number one, is that impact, right? Lessen the impacts on people that are detrimental, magnify the benefits to people, but also to bring people into this process and make sure that they are, I hate the word empowered because it doesn't really mean anything, but make sure people understand how to speak for themselves and are given the opportunity to speak for themselves in this process. Because we do so many things to communities, we do not do enough with them. And this is a tool that you can use to do things with communities, to create a plan to make everyone safer. I mentioned that there are several different kinds of HIAs. The fastest one that really doesn't involve community input is called a desk-based or a desktop HIA. That's if you're doing something what I think of as quick and dirty, right? You don't really have a lot of time. Maybe it's, your decision's going to be made next Tuesday at the meeting. So you need to write, it's more like a white paper at that point, right? And then you put it before the decision makers. A rapid is, that one can be done in 5-6 weeks. I've seen them done in 4 weeks, but not well, because you can't really do good community engagement in 4 weeks. But the rapid really looks at no more than 3 impacts. It's very limited. There's community input and engagement, but really where all the work happens is at that last point where you're making your action plan. And then the intermediate looks at many more impacts between 3 and 10, has extensive community engagement, can take 6 to 9 months. I've seen them take up to a year. And these are usually, sometimes they're funded projects, but mostly people have been working in these communities for a while. They already understand how things work. And whenever you get to the point where you can do an intermediate or a comprehensive with a community, then you have been embedded there for a while, right? And you are building something with the community, not just trust, but also a better, healthier place to live. So there's these different ones, right? And I'll also talk a little bit as we get towards the end about cumulative impact assessment. So making sure that you've identified the potential pathways, you've got the correct health outcomes that are both of interest and important to the community, of interest epidemiologically, I mean, right, like it affects a lot of people. And then the HIA team should evaluate the disproportionate burdens and impacts. If there are already existing disproportionalities or burdens, then those need to be factored in as vulnerability factors. I mentioned that a lot of these HIAs happen in communities that are already experiencing environmental justice issues, so this just magnifies it. And making sure that they're not limited to just the general things that epidemiologists like to look at. Here's what all the black folks have, and here's what all the white people have, right? And here's what young people have as diseases, right? It's not just that. It's what about people who've been exposed to occupational exposures? What about people who already have underlying respiratory conditions, right? You have to go beyond just the general, boxes that you see whenever you're looking at health data. I did put the pathway diagrams in there, yay. So as I mentioned, your pathway diagram is a good way to organize your knowledge about the health impacts, but it's also a great communication tool, right? Whenever you're talking to communities, and I have a tendency to do this because I'm an academic, but sometimes I use words that aren't accessible to everyone. And the pathway diagram gives you a different, and there's different learning styles, right? Like some people are visual learners. So you want to make sure that you've got that. And to guide your analysis, to make sure you keep coming back to that. Okay, what did we say the health impacts were? How did that get there? What are the pathways that we need to look at? Where are the intervention opportunities, right? That's what the pathway diagram. And so here's one for changing the speed limit. and you see like the speed limit gets lowered, and you have a change in collision risk and severity, right? Because if people are going slower, they're not getting hit as hard, and so it's not as bad of a wreck. Change in perceived safety, and then change in, that's your actual safety and your perceived safety, and then change in time spent sitting in traffic, right? So if you're going slower, traffic is moving, better, and you're not sitting in traffic, so you're not idling, you're not creating as much air pollution. But this is just a very simple one, right? Like to sort of show you the how they look. And using these to talk to people, and sometimes people give me more boxes to put in them, which is great because I don't know everything. I don't necessarily live there, right? So making sure that you're running this by people and that they're participating in its creation. Making sure that you define the role of everyone who's going to be participating in the HIA so that people know who to call about what. And inventory the assets. Maybe there are partners or community-based organizations that didn't express an interest yet that you're like, oh, they advocate around air quality. We need them, right? So making sure that you're analyzing that and looking at the data sets that are available, right? A lot of states now have these EJ screen type mapping applications, I guess they're called now. But they don't know everything, right? Sometimes you have to look at the CDC one and the state one and the federal EJ screen, right, to get everything you need. So making sure that the data you're going to need, the domains that you're looking at, if that's air quality or obesogenic foods or whatever it is, that you know where the data is and you know where the data gaps are. Just as importantly. Because in HIA, right, people are like, oh, well, that's not scientific. All you did was talk to people. Yes, I did talk to people. I did do some research, but I'm not an epidemiologist, right? I don't know everything. And so making sure that I have different data sets available to me and that I know what the limitations are on what I can suggest as a solution, because I have to be able to back up all of my solution suggestions with data, right, to show why we want to do it this way. So making sure that you have someone on your team who can do GIS visualization is becoming increasingly important. Heat maps are one of the most powerful communication tools to talk to communities about their vulnerabilities. And I don't mean just for heat, but I also mean for disease prevalence, right? Showing where the clusters are, where people live who have asthma, showing where the children live, right? So these kind of maps are really helpful. And then making sure that you have a designated person both in the community and on the paid team who's doing community engagement, who's responsible. The community has a human whose phone number and email address that they have to call. Because things come up and people want to be sure that they're not missing anything. There. And in the engaging in community with community members, making sure that you've got their voice, their current health and environmental concerns. Ask them, right? Just because it doesn't show up in the data doesn't mean it's not real. I take data communities all the time, and they're like, I don't know why they're worried about that. We have 10 people on one block with eyeball cancer, and they're talking to me about asthma. So make sure that the data that you've gathered resonates with communities, that it feels real to them, because sometimes they'll tell you, they don't know what they're talking about, or our air quality is bad just because their monitors aren't picking it up, or we're getting averaged out over our entire census tract, doesn't mean it's not real. And communities have been dismissed. They want to be listened to. And then make sure that you are identifying equity issues as they come up, making sure that you're addressing disproportionate impact. You're looking at the different community members and who's most vulnerable, and that you're ground truthing your findings. You say, okay, so I got these weird readings back on the air quality data. What do you think this means, people in this neighborhood who live right here? Or, going to your state or your federal partners and saying, this doesn't make sense, let's look at this together. Because sometimes, whenever you're collecting, especially if you're using community collected data, you want to make sure that you're validating all of your data, even federal and state data, with your community. And look to them, right? Community members gather all kinds of data that you wouldn't necessarily, if you were in a classroom, think of as data. But things like, every morning when I walk my dog, there's this weird smell, right? I don't smell it any other time of day. But it's coming from over there, right? Those kinds of feedback loops that your community leaders get all the time. Like my community leader in New Bedford, he gets calls 2 o'clock in the morning, and he will send me a text. And he'll say, Mrs. So-and-so has that weird smell in their basement again. Are y'all coming back to do indoor air quality monitoring? Right? And that's a real thing. So just making sure that you're ground truthing it and that you're co-creating your recommendations, right? Whatever you think as the researcher needs to be real to the community. And then this also increases your support for the HIA final product, and it enhances the community's capacity to advocate for themselves. It puts data in their hands so that they can take it to the next step. Engagement, as you're thinking about your engagement, making sure that you're doing your network analysis, right? It's not just who needs to be at the table now, but it's who do they know that they can bring? What resources do they have, and who else in their network could be involved or could contribute resources? Because your greatest source of resources, of capital, of people time, it's going to be from your community partners, right? People putting things in the pot that aren't necessarily money. So making sure that we're valuing that. And then making sure, I talked about that, what level of engagement with each group. And your stakeholders will include people who are impacted, right? Your primary stakeholders are people who are impacted, the people who are making the decision, and the people who live in the immediate surrounding community. But you might also have, secondary actors, people who own businesses in the community, or community-based organization. So just thinking about your stakeholders in a broader way when you're doing HIAs, because the more heads you have in the process, the better your outcomes are going to be. Different ways you can use your stakeholders. I always make sure that I have a community advisory group. They sort of are my first line of, hey, does this seem right to you? Or here's the draft screening and scoping. Please look at it and tear it apart. Get it back to me. Tell me what I'm missing. Right? They're sort of I call them my brain trust. Sometimes they think that's hilarious. But really, that's what they are. Right? You can also involve community members in your assessment process whenever you're looking at figuring out what the health impacts are, who's impacted, how far they're impacted. And I mentioned having them as a source of information, but also as a technical advisory. And do not overlook community champion, right? Having that person who can call their county commissioner or their city commissioner and say, hey, this is a really great project. We're doing cool stuff over here. You guys need to come and get on TV with us, right? At the end of your scoping process, you should have your goals for the HIA, your description of the impacted population and geography, your research question or questions, right? What is it that you're looking for? And then your list of people who are going to participate and what roles, at what point you're going to involve them in the engagement, and of course your pathways diagram. So then we move to assessment. And at assessment, what you're really doing is you're looking for the data to support what the community has told you, and you're using that pathways diagram to test whether these are really the impacts that are happening and whether they're severe. So in the assessment, you're really mobilizing data to predict impacts. So take your baseline health data and you'll look at what are the vulnerabilities, right? That's kind of epidemiological thing we do. What are, slice and dice your geographic data and make sure that you have looked at all the factors that are affecting vulnerability, that you've evaluated as many health outcomes as you can, and that you have described the health risk associated with each of those. And then taking your baseline data sets, right, and looking at those places that I mentioned, but also looking at environmental and policy conditions. It's an overlooked piece of HIA, right? What's the policy context in which this decision is occurring? Making sure that you are taking into account not just what we think of as like the atmospheric environment, but also the political environment, right? Is there somebody that doesn't want whatever this decision is to happen? Is there some kind of history or politics around it, right? Because that can matter in solutions. And then using the systems approach, look at the literature, review the links, see if those are applicable, look at other HIAs, look and see if the data that you need exists to make these predictions. If it doesn't exist, acknowledge those data gaps and do the best you can, because we don't know what causes human health changes, right? It's so multifactorial that we can't say this caused that. If you ever meet a public health person who tells you that, they're lying. Because we just don't know, right? There's all kinds of things that contribute to your vulnerability and your susceptibility. Some of them are genetic and individual, and some of them are population-based. I was in this session earlier where a lady was talking about how she grew up in a place that had terrible air quality, and now her son has asthma, right? And there's obesogenic and tetragenic effects that we just don't understand yet. So it's so multifactorial. But are there existing models, right? If you're using air quality, there are existing models that will tell you where it goes, right? We know that generally the people who are vulnerable live on the east side of town, and which way does the wind blow, right? Those kinds of things. And then, are there other HIAs or systematic studies that have already outlined these pathways and created a data set for you to use? When I first started, the first HIA that I ever did in the early 2000s, none of this existed. You go out and you start to look for systematic studies, and there just wasn't a lot of what I would call robust scientific data out there on the health impacts of the built environment. We've come a really long way, really fast in the last 20 years, and there's a lot of great data out there, but you have to dig to find it. And I mentioned where to find the data. Your key informant interviews and your stakeholder interviews will be key. And then also, those new screening tools. They're really great. The CDC has one. I put the EPA ones up here, but the CDC has a couple as well. ATSCR has one. So make sure that you're looking everywhere. CEQ has one. And when you're looking at impacts, you're really looking at these four pieces, right? What is the likelihood that these impacts are going to happen to these people? What is the magnitude, right? How severe are these impacts going to be? Is it just going to be a little bit to a few people, or is it going to be a lot, right? So understanding that, and then the severity, right? Can they be managed? Are there things that you can do that will lessen the severity, that will make it impact fewer people, right? And fewer people will get sick. And then who are the vulnerable populations? Making sure that you're understanding if there are certain segments of the population that are more vulnerable than others, that you're accounting for that. And this is what an impact table would look like. This is from an HIA I did a long time ago, where we were looking at limiting fast food in neighborhoods in Tampa, and basically looking at, what's the health outcome that we were trying to avoid. It's negative, its magnitude is high, its severity is high, right? If you're allowing a concentration of fast food restaurants in a community, and then what's the distribution? Lower income residents were more affected than higher income. So that's just one way of presenting it, but I like these kind of tables because they're very clear and they're crisp and they're really easy for people to understand. And then the fifth phase is reporting. So a lot of times in the beginning of HIA practice, reporting consisted of, okay, we worked with the community and we've got this great, HIA, and we worked with the community and they helped us craft this really great action plan on the back end of this, and here's what we're gonna do. Well, what people used to do in the beginning was they just wrote a 400-page report and they said, here you go, community, here's your HIA. See you, we're going to go to the next place and do an HIA, right? That's not useful, is it? Right? Just writing a report no one's going to read. So what I really like to do is I find that one-pagers, fact sheets, going and talking to people about the results. I make a slide deck for my community folks. So, I'm never the person presenting the HIA to the county commissioners. It's always whoever my community leader is, because they're the person who's going to have to live with it, right? They're the person who's the advocate. They can point in the back of the room, oh, there's Dr. Whitehead, she's helped us do this. And it's just because they need an expert from out of town to tell them something, right? But they own it, right? It's theirs. One time we made a video, which was hilarious because the kids from the neighborhood did a hip hop song that talked about the results of the HIA and how they were going to, and they did the hip hop song at the county commission meeting, which was really cool. And we won. We got them to change their mind about the decision. So use cute kids is my point. Middle schoolers, if you can swing it. And then evaluation, right? You never want to finish any kind of process and not do an evaluation. And in HIA, we, do all three kinds. Oops, I went the wrong way. We do all three kinds, right? Outcome, process, and impact. The outcome, did we establish new partnerships? Did we elevate health to a way that it wasn't talked about before? Excuse me, how many of our community concerns were we able to incorporate and address in our plan? And then the impact, right? We used to say, literally, this is how we would do impact assessment. We would go, okay, decision makers, when we gave you this HIA information, did that make any difference to you? Did that change your mind at all? Right? That's a dumb way to talk about it. What we really need to do is we need to look at how many of the recommendations in the action plan were adopted, how many were implemented, how many just got, this, thank you very much, community, and, were the community included in the implementation, right? We sold them this plan that they were going to be included, so were they actually included? And then were health considerations institutionalized in any way? Because really, health impact assessment is part of this bigger framework of health and all policies, where you're really trying to get people to think about the health impacts of their decisions. And so thinking about institutionalization, it's more around, will they do another HIA? Did they put health in their comp plan? Right? Did they, through this decision, did they make it a criteria for future county commission decisions? Right? So how or if health was institutionalized is an important consideration. And then your process evaluation, did you meet all of the goals that you set out? Did you follow the minimum elements and practice standards for HIA? This is, HIA, as I mentioned at the beginning, is very established. We are on, I think, the 4th version of the North American practice standards and minimum elements. So, really, there's a robust practice. There are standards that you can go by. There's a handbook that Sophia has. And then, was the HIA successful, right? Like, did people feel included? Did people feel heard? Was their feedback actually incorporated and used, right? Did they feel like this was important for them? And, did you do your stakeholder analysis? Whenever you did that, did you identify all the people who needed to be in the room? Did you miss people, right? Like, so thinking about this whole process, what did it look like? How included did people feel? And what was the decision context, right? And then impact evaluation is always hard, right, for any process. So, thinking like, so impact evaluation is, what difference did the HIA make, right? So there are the questions that I asked for that, did the HIA have unintended consequences? Sometimes unintended consequences are great, right? Maybe you partnered with some organization you never partnered with before, and you got a new partnership, or you guys found out that one partner has resources to do something you've been trying to do for 5 years. Just by coming together and working on this project, you found other things to do together, right? That's an important outcome. But it could also be that by working with the community, they discovered that they, could do things more independently, or I don't know. There's all kinds of impacts. And then really thinking about, how did the HIA change any of the institutions involved? Right? Did it open their eyes? Are they thinking about health in a different way? Are they thinking about this community in a different way? And are the community thinking about themselves in a different way? I think those are important outcomes because those speak to the purposes of doing HIA. Really, it's really to help the community that's impacted by a decision participate in that solution, right? Where that decision is going to be in their community. And then outcome evaluation, I think I talked about this, yeah. So I'm gonna be honest with you. When you get to evaluation of HIA, you're out of money, right? You've spent all your money doing all the other things. And rarely do you see this, right? Outcome evaluation is hard, it's expensive, and with health data, you have to wait, so long to see whether those outcomes occurred. So the best we can do is to sort of approximate outcome data by looking at, did it really make a difference in the health outcomes? Did the thing that you changed with your engagement, with your recommendation in this decision, is that going to make a difference long-term for that community? You don't know sometimes, right, until well after. But it's good to try, right, because I'm going to be honest, most people spend their money doing engagement and never get this far. They write the report at the end, the action plan with their community. Like what I usually do is we write the action plan together, and then we say who's going to be responsible for each of the tasks, what's our timeline, and then I give that to the community. And it's up to them. A lot of times the steering committee will take this over, but as the researcher, I'm usually done at that point, right? It's up to them to hold their community accountable, because sometimes the things that you predicted in the HIA go the other way. And the community comes back to the decision makers and they say, hey, when we did this HIA and we redesigned this process to do these things, it did these things which aren't so good, so we need to revisit this. That's the purpose of monitoring and evaluation, to make sure that there aren't unintended consequences that are causing harm. And here's the monitoring piece of it. Like I said, a lot of times you'll put this at the end of your action plan and hope that the community picks it up and does it. All right. And as I mentioned, we have indicators for each of the impacts, and a lot of times I'll put thresholds. If it goes across, this far, then you need a new intervention, right? And then I mentioned we assign responsibility and triggers for adjustments. And then we leave you with this last slide. I think that cumulative impact assessment is HIA 2.0. I spent most of the last 20 years talking about teaching people how to do HIA and doing HIA with communities. And I see CIA as sort of that next nexus for HIA to evolve into. Cumulative impact doesn't just look at, you know, in HIA, you're like, here are my baseline conditions. It's a snapshot of where we are now. Cumulative impact assessment looks backward at first. It looks at structural issues. It looks at how did this community get to be this way? What are the policy drivers? What are the structural drivers that created these vulnerabilities? And how do we fix that first before we do something else to them? That's why I like cumulative impact assessment. I think it's going to be very powerful. The EPA is, they are coming along with their thoughts about how cumulative impact assessment should be done. And, you know, it's very complicated, right? You need scientists with all these degrees and things the way they've got it designed. But it doesn't have to be that, right? It should be this community-centered, community-led process because the community knows what the structural drivers are. They know what racism has done to their community. They know what zoning did to their community. They know what the what is that called? Not re-urbanization, but in the 70s when they went in and they put in the roads and they broke up the communities. Thank you, urban renewal. I couldn't come up with the word. Urban renewal, they know what these things did to their community. They know what it caused. So I think that cumulative impact assessment is the future of this work. And I'll leave it there. So I'll take questions if anybody has any.
Thank you for that. Going through this, my main question was, how do you avoid biases in that, you know, if you have somebody who says, I have asthma from air, as a researcher, are you not inherently going to be looking for data that would support that assumption?
It depends. I will probably already have looked at the air data to see what, you know, it is. But a lot of times it's more that propensity of people, right? There's a concentration of people with asthma. There's a concentration, but I don't know if that's what caused their asthma. Right, so I asked them about their situation. I asked them about their house. I asked them how long they've lived in this community next to whatever the source is. Right.
I guess in my head, I'm thinking like a standard scientific paper where you would have a null hypothesis and you're testing against that specific condition. In this instance, it seems like that condition could be variable or it could be multiple. You know,
factorial. Yeah.
To test for.
Yeah, you're not going to get to that level of detail. Right, you're not going to know what caused their asthma. You can have like general idea from what the conditions are in the neighborhood, from the sources. You can look at the plumes, right, and you can look at air modeling data, but you're not going to know, right, if the air quality really caused their asthma. It could be obese. It could be tetragenic. It's a lot of things. It could be, and we're not going to avoid bias, right, because we're humans. Yes, ma'am.
Question about how small a community this could be applied to. You know, when you think about predicting something and how, like, you need big numbers. So I wonder how small can you be?
A lot of times I think what you could do is you could look at other communities, right, and sort of see how other communities with these issues, right, and you could sort of use those as comparators because you can't really, like you said, right, like with 200 people, it's really hard. Now, one time we did do this because the neighborhood was only 325 people. We went door to door and we talked to everybody. I had interns, don't look at me that way. But we did, right? Like we sat down with them, we talked to them about their health history, we talked to them about their health conditions, we asked them how long they lived in the neighborhood, we asked, you know, about their house. We do that. So, I mean, you know, when you have a small enough population, sometimes you can talk to everybody, but usually you can't. You have to rely on, you know, statistical data at that point. Say other communities that look like this have these characteristics. Yes, sir.
Would you be able to have like a portal where these people who are impacted, say they have asthma, that could report report in when they're having attacks, and we see that populations are having attacks, and it's a high pollutant, day, make that correlation.
You could, hyper-localize. Yes, sir.
My question is a little bit more about the follow-up after. What does accountability, I guess, look like, not only just for the stakeholders who are part of it, but for the people who are responsible for what I'm hearing recommendations should be implemented? How are you, in your experience, how have you been able to navigate that in a way to help get some communities to get the recommendations?
Primarily through the monitoring plan, right? So at different increments, there's like, okay, here's the threshold, here's 3 months out from this decision, we're going to look at these data, and if these data don't go the way that we think they should have gone, then the community has that loop where they can go back to the decision maker and say, hey, this is not working the way it was supposed to work. We need to do something different. But it does rely on the community taking that data up and really advocating for themselves. Sometimes the health department, if they're your partner, they will do that advocacy too. Yes, ma'am. And then you.
So I'm just thinking about some of the things that you said, and I'm trying to think about that they're mostly, based on data for health effects versus like how that would apply to communities that might be concerned about something that hasn't happened yet. And specifically thinking about like the National Academy of Sciences has called for health impact assessment for different technologies related to decarbonization and their co-benefits and their just impact for different infrastructure decisions. So I'm just curious, like when you're looking at something that's predictive versus actual, how that impacts the methodology, I guess.
It's squishy. Right. And that's the big criticism of HIA, right? That sometimes it's squishy and you don't know. You have too small a population, or, you're looking at other studies that don't necessarily apply to the, it's not this community's data that you're looking at, right? You're using a proxy. And I mean, it's a weakness. It's a methodological weakness. And the best you can do is try to triangulate your data.
Is to try to what?
Triangulate your data. Sophia? Oh, that's right. I forgot.
Sorry, I know we're out of time, but a viewer from the live stream asked, can you share a completed impact assessment, health assessment, impact assessment?
Go to Community Commons, and there's like 300 or 400 on their HIA site. But it's communitycommons.org and /HIA. And so there's a whole bunch of them there, historical ones. And you can also go to HIAsociety.org, which is Sophia's website, and we have sample HIAs on there as well. All right, I'm getting the get off the stage, but I'll be around, so if people want to ask other questions, I'll be hanging out. Thank you all for coming.